So here is the Naso-Palatine injection lecture and a review. So when you need a soft tissue anesthesia on the lingual, on the palatal side, canine to canine, and the palatal bone, then you would be giving the nasopalatine. So it gets both the right nasopalatine nerve and the left nasopalatine nerve. So that's why it gets that grouping. This is also a pressure technique on this injection. You are going to put pressure with a cotton tip applicator on the incisive papilla. And it will look just like this. So you're pushing the incisive papilla kind of off to one side, and that's the pressure that you're wanting to give it. And then you're going to inject on the opposite side where that bulbous part of the papilla meets the actual palate. In that little line there where those two meet, that's where we're going to insert the needle. We don't ever inject right into the papilla. We angle underneath it. And it states in the chapter, and you would do good to pay heed to this. It says, with no other injection technique is the need for strict adherence to the protocol of an atraumatic injection more important than with the nasopalatine nerve block. So the book is going to show you two different approaches. We do one of them, we don't do the other. One of them, if you look at the pictures in the book, one of them will have one injection and the other one needs 3 injections. So soft tissue between the maxillary central incisors is thick, dense, so it's firmly attached to the underlying bone and it's quite sensitive. So your first injection, if you were doing the 3 injection one, the first injection is going to go into the side of the incisive papilla, and you will be depositing some anesthesia here, so that will be getting numb. So when that gets numb, it gets numb into the kind of to the front of the papilla also. So your second injection is into the labial frenum, and you go right into the facial on the labial side into that frenum. The second injection into the papilla between the centrals, and the third injection directly into the incisive papilla. So areas anesthetized are going to be the anterior portion of the hard palate and hard bilateral from the mesial of the right premolar to the mesial of the left first premolar. And the nerves that you're going to anesthetize is the name of the injection, the nasopalatine nerves and all of its branches. So we are going to do the injection to where there's just one injection and we're not going into all those different places. We are just going to inject underneath to the side of the incisive papilla. So we are going to insert just lateral to the incisive papilla. You're going to be holding that cotton tip applicator on that papilla from the other side, and you're going to apply that pressure during the entire injection process. It's going to be at a 45 degrees angle, and the bevel is going to be to the soft tissues, and the target is the incisive foramen underneath the incisive papilla. That's what we're trying to get to. I'll let you read through this procedure, but you obviously have them open super wide, extend the neck and turn their head. Apply the topical as usual. The bevel goes at the on the soft tissue side, and you're going to slowly advance the needle toward the incisive foramen until bone is gently contacted. And guess what? It's usually about 5 millimeters again, so not too hard to memorize. So after contacting bone, you're going to aspirate in 2 planes, and you're going to withdraw the needle, of course, about at least 1 millimeter. If it's negative, you're going to slowly deposit no more than 1/4 of local anesthesia over 15 to 30 seconds. It takes longer on a 30-second almost because that area is so dense. And so you feel like you're just pushing with all your might to get some of that anesthetic to diffuse into that area. So you will have 1/4. On the greater Palatine, you can give like 1/4 to 1/3, but on the nasal Palatine, no more than 1/4. That's it. Okay, so the injection can stop when the ischemia from the local anesthetic spreads further than the ischemia happened from the cotton tip applicator. So you'll see some white blanching, and that should be normal. Then you're going to make your needle safe and wait 2 to 3 minutes. Don't insert directly into the incisive papilla. It's very painful and can cause infection. Do not deposit too rapidly. Don't deposit too much, not over 1/4. This is a highly successful injection with very few complications at over 95%. Hematoma is always possible, but extremely rare. And due to the thickness of the bone, the local anesthetic may squirt back in the patient's mouth, and while you're trying to make it diffuse into the tissue. There's no clinical significance to that. Just remain calm if it happens and calm your patient. If there's inadequate anesthesia of the maxillary first premolar or canine, it could be because there's crossover innervation from the greater Palatine. To remedy that, you would also give the greater Palatine injection. The nerves anesthetized are the terminal branches of the greater Palatine or the nasopalatine on these. It's only getting soft tissue, so remember, there's no teeth, no pulpal. Primarily for procedures involving more than 2 teeth and for hemostasis. Positive aspiration on the palate is negligible, but it is possible. Area of insertion is 5 to 10 millimeters from the free margin at a 45-degree angle for the greater Palatine. So that's usually what it is. And area of insertion for the nasopalatine would be, of course, at a 45-degree angle, about 5 millimeters at the side of the incisive papilla. I'm going to say a few things about distractor techniques. These are things that when a dentist is giving an injection, how he palpates the lip with his fingers going back and forth, or moves the lip up and down to kind of distract from the fact that he is giving this. And they have actual handheld distractors that can put a little buzz or a little massaging effect on the lip, and some of them are kind of built into mirrors, into just tissue retractors, and there's all sorts of little different things for distractors that you may come across when you're in actual private practice. We don't have any of that in the clinic, so we are just going to go ahead and give injections without these distractor techniques. And a lot of times, as this says, it can actually increase the patient discomfort because using them can cause the needle bevel to be moved up and down or vibrated real fast, and the anesthetic solution may be deposited further away from the target site. So that's one of the reasons that we don't tend to be real fond of them. I promise you, you will. If we were in school right now, we would have had this lecture yesterday, and you would be giving these injections to each other today. So this is just giving you an opportunity to be able to study a little bit more until we can get back into our normal lives, into the school. All right, so that's it. If anyone has any questions over any of these, please feel free to contact me.